So I'm going to try to level set for everyone here. Just go because I know there's a very diverse crowd. We've got everyone from folks working in industry to leaders in the field who we've invited here today. So I'm just going to go over the basics of pulmonary hypertension, and please feel free to ask questions. I have way too many slides, so I'll start my disclosures. So when we talk about the definition of pulmonary hypertension, we have to remember the updated definition where it's now a mean PA pressure greater than 20 millimeters of mercury. So that's 1% of the global population. So something when I was training, when we'd always hear pulmonary hypertension is something rare and you get worried about it. Now you have to keep in mind when we use this term, it refers to a lot of patients. And why do we have this new definition? Because in population-based studies, we see an increase in mortality when, I don't know if this is gonna show up. Oh, there we go. An increase in mortality when the mean PA pressure is greater than 20, as well as an increase in mortality when the PVR is greater than 2 Wood units, because these are associated with the development of right heart failure. What are the symptoms of pulmonary hypertension? We're really talking about dyspnea being the main symptom when most people present. I think people present earlier now than some of these rarer symptoms, which were associated with more advanced disease, especially things like dysphonia. And s although we will see exertional chest pain and chemoptysis is pretty rare, but dyspnea on exertion really is the most common symptom that we see. When we talk about the groups of pulmonary hypertension, we have this clinical classification. And we have to remember that pH is a clinical diagnosis at the end of the day. We have to integrate data from multiple tests and our expertise to come up with a diagnosis. And so I'm going to go through all the groups, but I'm just going to mention them briefly here. With group one, pulmonary hypertension being pulmonary arterial hypertension, which is what most of us really focus on because here it is a rare disease, around 50 per million, but it's due to remodeling of the pulmonary arterioles, really obliterative obstructive disease that causes right heart failure, where we have all of these now wonderful therapies that improve outcomes. Now, the most common form of pulmonary hypertension is group 2 PH due to left heart disease. And this can be isolated post-capillary pH or IPC pH. That's where we just see an increase in the left-sided filling pressures alone, or we can see combined pre and post-capillary pH, where there's also an elevation in the pulmonary vascular resistance. This is again the most common, around 70% of pH. Next most common is pH due to chronic lung disease, group 3 pH. This could be non-severe or severe pH. And now we have treatments that actually improve exertional capacity in that disease. Group 4 is pH due to PA obstructions, most commonly chronic thromboembolic pH. And there are gonna be some talks about that later today. So, again, and we have special treatments for that compared to the other forms of pH. And then group 5 is pH due to unclear or multifactorial mechanisms, really a grab bag of different systemic diseases such as hemolytic anemias, sarcoidosis, and cancer. Now, how do we diagnose our patients with pH? Well, of course, it relies on our medical history initially and symptoms when they present. And then most folks get simple non-invasive tests, right? They're going to get chest X-rays, ECG, some lab tests, especially BNP or NT-proBNP. And the most important test really for screening for pH is echocardiography. And I will say this is from the World Symposium pH consensus document. It's tough to keep both cardiologists and pulmonologists happy with these guidelines, right? Because the pulmonologists will say, "Look, oh, you need to get PFTs immediately. That's gonna, provide some really important insight." The cardiologist says, "All you need is an echo, and then we can move to right heart cath." So there's but I'm just gonna highlight echo here because it is really the most important screening tool for pH. And there are signs here specific for PA that really increase our uh, the risk for PAH based on this. We talk about having an echo probability of PAH. Some of this, frequently we just talk about the RVSP, the right ventricular systolic pressure, which gives us an estimate of the PA systolic pressure. But it's much more than that. It's also, we want to see signs of right heart remodeling. And there are many of them. I've just chosen a few of these from the ESC ERS guidelines. Obviously, we can see right ventricular enlargement. We can look at tricuspid annular plain systolic excursion, or TAPSE. We can look at tissue Doppler imaging of the right ventricle, giving us an S prime. We can look at right atrial remodeling. But here's RVSP, again, just one of many of these echo signs that should make us concerned about pulmonary arterial hypertension. And I put this slide back here just to remind everyone, if you're talking about PAH, everyone needs to get a VQ scan, because all of us have been burnt. I mean, like, every single one of us have been burnt thinking that there's a patient with PAH who ends up actually having CTEPH. And this just happened to me a couple of months ago with a patient from Africa who I thought had a wonderful story for PAH, had a CT scan that was pretty normal, but then got a VQ that was horribly abnormal. So everyone needs a VQ scan. Okay. And then ideally, folks will be referred to a PH center where they can get right heart catheterization, which is required for the diagnosis of PH. And at right heart cath, we can look at the hemodynamic criteria for pH. I already mentioned again, pH is a mean PA pressure greater than 20. But then again, precapillary pH, and this is for folks who are going to fall into groups 1, 3, 4, and 5, is that a normal wedge pressure less than or equal to 15 with a PVR greater than 2 Wood units. And then for the group 2 patients, you can either see, again, isolated postcapillary pH or combined post and precapillary pH. I will also mention there is a group of patients who have exercise pH. To diagnose folks with this, you have to do an invasive cardiopulmonary exercise test. It's very rare to see this, although I think the more expert centers who do this frequently do see cases, especially Aaron Waxman's group at the Brigham. Okay, I'm going to spend a few slides now looking at each of these pH groups in a little more detail. So group 1 PH, PAH, again, is due to obliterative remodeling of the pulmonary arterioles, and this sort of pathognomonic lesion is this plexiform lesion that we now know are actually due to collaterals being formed from the vasa vasorum and systemic vessels into the pulmonary arteries. You're obliterating these vessels, they secrete VEGF, and then you get angiogenesis and formation of these plexiform lesions. And again, by obliterating these lesions, you're increasing pulmonary vascular resistance, and you end up with right heart failure. Genetic testing is recommended for idiopathic PAH patients, and indeed there are a number of mutations that are seen in both pediatric and adult patients, the most common of which is the BMPR2 mutation. And so BMPR2 is around 70% of hereditary PAH is due to mutations in BMPR2. And we talk about treatment of PAH. It's important. One of the key things is to perform a risk assessment, because that's going to guide your treatment. When a patient presents, you're going to perform a risk assessment. If they're not high risk, you're going to do dual oral therapy. If they're higher risk, you can do triple therapy, as seen here with the parenteral prostacyclin, in addition to the ERA and PDE5 inhibitor. You'll follow up at 3 to 4 months with another risk assessment, here a 4-strata risk. And based on that, essentially, you're going to keep on adding therapies until someone reaches low risk. And if they're persistently in this intermediate high or high risk group, they're going to refer them to lung transplantation. And what are our goals? Our treatment goals are to improve people's exercise tolerance, their RV function, and their hemodynamics, as outlined in the World Symposium document. Now, we're having one of the world's experts on risk assessment talk later, right after me, so I'm not going to talk much about risk assessment. I'll just say there are many ways to do it. There's REVEAL, there are ESC, ERS risk scores. Again, follow-up, we go to this 4 risk strata, although I think all of this is subject to change in the near future, because now we also see 6 strata, and because really defining this low risk population keeps on changing. What's acceptable for being low risk? We want someone to have a long-term outstanding outcome, right? So there is a difference between patients who have a low risk, where again, 1-year outcome, 99% survival, but at 3-year, 91%, compared to a intermediate low, well, it's like a low intermediate low risk, this strata here, where that 3-year survival is a little worse. So maybe we have to push patients to get into this low risk category. And Val recognizes this slide, and I'm sure she'll show it in the next presentation. But again, improving risk category is associated with improved mortality. So there's strong data supporting this approach of treating based on risk. Now, how about the therapies? I just sort of blew by them, just telling you, hey, we're adding all of these therapies here. And this is all subject to change, I think, in the near future with emerging data on sotatercept. But when we talk about the pathways that we treat for PAH, they fall into four categories. So here, this is endothelin receptor antagonists, block the type A and B endothelin receptors, which are expressed in smooth muscles. Those receptors promote smooth muscle cell proliferation and vasoconstriction. So by blocking them, you have beneficial effects. Now, nitric oxide is a very important, oops, I'll go back if I can figure out how to go back. There we go. Okay. Nitric oxide is a very important vasodilator, right? It's secreted by endothelial cells, endothelial-derived relaxation factor. And so we can target this pathway either to increase the signaling through SGC stimulators or PDE5 inhibitors. Then we have the prostacyclin pathway here. IP receptors expressed in smooth muscle cells promote vasodilation. So we treat with prostacyclin pathway agonists, and there are many flavors of this: parenteral, so that's IV, sub-Q, inhaled, oral. And I'm sure if I start trying to say which is best, there'll be a fight, probably in the back of the room, not in the front. Okay. And then most recently, we have this activin BMP pathway where we can target activins with activin signaling inhibitors that prevent signaling through these receptors and promote increased signaling through that BMPR2 receptor, where loss of function mutations are associated with hereditary PAH. Of course, we still don't really understand how the activin signaling inhibitors work, depending on who you talk to. They'll tell you that they bind to different set of ligands. Some people will say, oh, most of the effect is through binding VMP9. Others will tell you it's by binding other activins. But we do know that sotatercept now has shown benefit in high-risk populations. This is data from Zenith, where you can look at the decreased risk of events, this primary composite endpoint, where sotatercept significantly improved outcomes compared to placebo here. And if you looked at mortality, or this is looking at transplantation-free survival, there was even an effect here with a hazard ratio of 0.34. So most recently, sotatercept has been tested in a lower risk population. So the population in both Stellar and Zenith were primarily patients who, again, Stellar were primarily on triple therapy, prostacyclins, especially Zenith, again, a high risk population. Most of these folks on prostacyclins as well. But now we have data from Hyperion where the majority of patients were on dual oral therapy. And we see that in Hyperion, a similar type of benefit is observed where sotatercept showed significant benefit compared to placebo in patients who had been on therapy for less than a year, and again, the majority of which on dual oral therapy. So this treatment algorithm, which came out before this data, is going to be subject to change. And I think all of us are making it up as we go along here, but as we get more experience, I think it'll guide the development of the next treatment algorithm. Now, I don't want to suggest that everything with sotatercept is, wearing like rose-colored glasses here. There are side effects that we have to keep in mind. So when we look at telangiectasias, there is a risk of telangiectasias, although it appears to stabilize out after, a couple of years. The risk of telangiectasias does not seem to increase. But other side effects have been reported, such as development of pulmonary AVMs, although they don't appear to be super clinically important. These are just picked up on bubble studies. They don't seem to be associated with the development of hypoxemia. And then also pericardial effusions, which this has been seen in observational data, but wasn't seen in the randomized clinical trials. So there's some question is, do you have to just wait longer to see it? I think when we get more data from Soteria, we'll have more insight into this. But it does appear that a number of centers have observed this. Okay, that's enough for pH. How about group 2 pH? So group 2 pH is really a spectrum. Now we can see it in any form of left heart failure with preserved ejection fraction, reduced ejection fraction, valvular disease. But over time, it's thought that this pulmonary congestion can lead to pulmonary venous remodeling here. and that can lead to an increased pulmonary vascular resistance and the development of combined post and pre-capillary pH, which can lead to right heart failure, dysfunction, and much worse outcomes. But there's always been, I mean, at least like when I started around 15 years ago as faculty, frequently we give these types of patients sildenafil. There were a couple of trials that changed my practice here. I'll just mention a few of them. So one is the CIEVAC trial. This was a trial done in Spain at multiple centers. And what this showed was that in a group 2 pH population, these were folks who had uh, surgically corrected valvular disease, but still had a persistently high PVR. And what they saw was that outcomes were significantly worse with sildenafil in terms of look at the major clinical events here. So sildenafil isn't something you can just sprinkle on people, someone's got group 2 pH. This is something which unfortunately I think still happens a lot, is a physician will just look, okay, here, have some sildenafil. And it's associated with worse outcomes, more heart failure, more events. And this was across, as you can see in this forest plot, everything, all the people that they saw, whether it was reduced or preserved ejection fraction, et cetera, or high or low PVR, even in this group with a PVR greater than 3 Wood units. But there are some other drugs that do seem to show some benefit. What don't SGLT2 inhibitors work in? We haven't found anything that they haven't worked on yet. Maybe some cancer, I don't know. But this is empagliflozin in the EMBRACE-HF trial. They saw a significant decrease in the PA mean pressure over time. So it's likely with some of our newer therapies for heart failure, that by decongesting patients over time, it's going to improve their pulmonary vascular remodeling. And this has been suggested. This is approach Ryan Tedford and colleagues proposed, in terms of what therapies could be appropriate in these CPC-PH patients, in terms of SGLT2 inhibitors, maybe these MRAs and ARNIs, but, probably not these other ones down here. Although I will say there is a little data now for ERAs in the LVAD population from the Soprano trial, which showed a decrease in PVR. Okay, how about group 3 pH? Now, of course, you can see it in any chronic lung disease, COPD, ILD, or in between, we have CPFE. But really, the data that we have for showing a benefit of these therapies, or really of one therapy, is in PH-ILD. And in PH-ILD, first off, how do we evaluate these patients? You want to really assess whether we think the degree of their disease is essential when we diagnose them. One of the most important things is screening them, first of all. Patients with ILD especially should be screened for pulmonary hypertension. I think at a lot of places, and still even at our institution, sometimes there's not a clear protocol for screening these folks. And that could be echo, BNP, other testing. But whenever a patient with ILD has an acute worsening and it's their CT scans unchanged, pH should be like right at the top of your list as to what could be contributing to their worsening. And we do know that inhaled treprostinil shows a benefit here. There seems to be, and if you look at the dose, it seems to be in that group that there is a dose response here when you get to a dose greater than or equal to 9 breaths. This is using the nebulizer. You can see an improvement in their exercise capacity. Now, this isn't true for all pH therapies. For example, Riosaguat showed harm in the ILD population. My last slide here. For CTEPH, therapies are completely different. Here, it's really about treating this obstructive lesion. So you end up with a pulmonary embolism, and it causes scarring in the vasculature. So this isn't really a blood clot anymore. It's a scar. And so it can either be, if it's proximal enough, it can be removed surgically with pulmonary endarterectomy. If it's more in these subsegmental or subsegmental vessels, you can balloon these open, and surprisingly, they actually stay open. You don't need to stent them or anything like that. But then if you do have this sort of microvasculopathy, this acts a lot more like PAH, and these are best treated with, these can be treated with medical therapy. They're not going to be amenable to PEA or BPA. So you really want to refer your patients to an expert center where all of these options are available, or at least that discussion can occur. All right. So with that, and I've taken around 25 minutes to tell you everything you need to know about pulmonary hypertension. I'll thank you for your time and I'm happy to answer any questions.